Brian. Very much like to thank DePuy for hosting this, and I'm honored to be here to present to the team. So I'm going to start by talking a little bit about patient selection as well as perioperative management for patients in outpatient total joint replacement. Many of you may be doing this already or may be pondering the possibility of starting an outpatient total joint program. We've been doing this now for several years, so we've got some experience with that. I'll go through and give you some of our pearls. Here's my disclosures. Most important, I do some consulting and product development for DePuy Synthes. So I think when you implement a program with outpatient total joint, the first thing is that we do this without increasing the risks to the patient or long-term outcomes. We learned this saying in medical school, and I think it still applies. But I strongly believe that outpatient total joint can be implemented, and it can be better for patients. It can increase patient satisfaction. You can do it with a low rate, if not a lower rate of complications. And in the end, I think it can reduce costs. The question is, how do you get there? Well, when you talk about medical management, I think the best way to medically manage your patients post-op is to do some patient selection. Choose patients that require little to no medical management. And I think a lot of this is common sense, but I'll go through some of the thought process. When you look at some of the published data on this, here's an article from Dr. Mesko looking at the Charlson Comorbidity Index and the chance of readmission. And they saw that if you have myocardial infarction history, CHF, vascular disease, this whole laundry list of problems, and your comorbidity index was greater than 2, it increased the risk of readmission. General anesthesia was also a risk factor, which is why we favor regional anesthesia. Obviously, if you need a blood transfusion, that's not particularly amenable to outpatient surgery. Other conditions that require additional interventions, in this article by Paul Courtney, they looked at over 1,000 total joints, and of those, 7% required medical intervention. Most of those, however, happened greater than 24 hours later. Those included conditions such as COPD, congestive heart failure, coronary artery disease, and cirrhosis. Some of this data can be used to help to select your patients appropriately. So, for outpatient total joint, I think a good place to start, avoid significant cardiac conditions. That's fairly obvious. For patients with pulmonary conditions, COPD is probably pretty obvious, but untreated sleep apnea. If you have well-treated sleep apnea, I think you can do outpatient surgery, but untreated sleep apnea is a bit of a concern. Urinary retention is a place where we get into some problems, so if you have a patient with a history of this, BPH or prostate cancer, especially the elderly male, I think you need to be aware that these patients can have problems with urination post-op. Dementia is one to avoid, although sometimes getting patients home sooner can help with the sundowning that people get in the hospital. And liver and kidney disease is obviously a warning sign as well. So how do I screen? I start fairly simple. I used age and BMI as a basic screening tool. So when I started, I said, okay, I'm not going to do anyone over the age of 65, and maybe I'll start with a BMI of under 35. And if you do this, this eliminates many or most of those conditions that we talked about on the previous slides. You can then titrate that up over time. Now if you're up to the age of 70, 75, and BMI maybe up to 40, I consider you a candidate at least to start with for outpatient surgery. And I think age is probably less important. Maybe more important is the overall health and motivation. If you use this screening tactic, then most of those conditions that we talked about, like COPD, cardiac conditions, sleep apnea, most of that is filtered out with eliminating the obese. Most of these problems are taken care of, and then you have to just screen for some obvious medical problems in all of your patients. So when the patients arrive to the facility, I like to do my outpatient cases early in the day to give proper time so that we can get these patients through the system and get them home. Everybody gets Hibiclens wipes. That's irrelevant when it comes to outpatient. We do that for all patients. Same thing with a scopolamine patch to reduce nausea, although we now avoid that in glaucoma, as well as concerns for urinary retention. When it comes to perioperative blood management, it's really obvious and important that you eliminate, if not reduce, the transfusion rate to a very low rate. When I do these cases out of a surgery center, I have no access to blood products, And if you're going to do it from the hospital, you want your transfusion rate to be essentially 0. So before I moved my patients to the surgery center, I made sure that my transfusion rate was predictably very low, preferably under 5%. If your transfusion rate's much over 5%, you may have some work to do with getting your blood program in check. I then try to identify preoperative anemia. I can use this non-invasive finger monitor or simply get an H&H so I know where people are starting. And then I like to identify high-risk patients. So I like to look at the overall blood volume, especially females who are thin. They tend to have lower overall blood volumes. They also tend to run anemic. So if I've got a female who's thin and small and she has preoperative anemia, that's the patient that I worry about, even with an average blood loss, getting into significant post-op anemia. If you get some of these larger males, this guy who's 6'2", 220 pounds, you can lose a boatload of blood and not worry about the need for transfusion. I like to give everybody a pre-op iron supplement. And then if patients have low blood volume and if their hemoglobin's low, then I either, or if the hemoglobin is reasonable and it's a total knee, then I'll just move them to the main hospital. Or I will postpone their surgery, send them to the appropriate consultant, and try to increase their preoperative hemoglobin. Intraoperatively, to reduce blood loss, obviously you've got to be able to do the surgery well. That goes without saying. I think you need to be able to do it efficiently as well. Spinal anesthesia and intraoperative hypotension, I think, are really helpful to reduce blood loss. I like the mean arterial pressure to be under 60 millimeters of mercury. That can be addressed with spinal anesthesia as well as some propofol. Some occasional pressors can help or antihypertensives can help to reduce intraoperative blood pressure. But if I see significant intraoperative bleeding, the first thing I do is, of course, identify anesthesia as the culprit because it could never be my fault. And I ask them, what's the mean arterial pressure? And if it's not under 60, I ask them to politely lower that, please. I think if you lower your operative time, and I'm not suggesting that you rush through these surgeries, but efficient, organized, quality surgery, leave a dry field. I don't think you need drains for these cases, and all these tools can help to reduce blood loss. The transfusion triggers, I think these have evolved over time. I think we all know that. But if you do these as an outpatient thing, outpatient surgery, the beautiful thing is there are no transfusion triggers because the patients are home. Now, on occasion, when I first started this, I did get home finger stick hemoglobins by the home health care, but I've essentially aborted this practice as my confidence has grown and the rate of transfusion has dropped so low. As far as perioperative medical management, I use VTE prophylaxis via risk stratification. Do the same thing that I would as an inpatient. I give aspirin and portable compression devices for my standard risk patient, but this eliminates the need for monitoring warfarin or some of the stronger anticoagulants. I think it's critical that you have a backup plan for these patients if medical intervention is required, especially if you're doing this in a freestanding surgery center. You need to know, what's my adjacent hospital? Is this a hospital-associated surgery center? Or in my case, I'm in a freestanding surgery center. The closest hospital is probably 5 miles away. I've got a Jose Bank close, but it's not a hospital. So I need to know, where can I admit the patient and how do I make that happen? I think sleep apnea is something you need to address, especially untreated sleep apnea. For my patients who are morbidly obese, I keep a close eye on this. And if you've got sleep apnea, then I suggest they use the CPAP for the perioperative time frame, especially the first few nights after surgery. I recommend they elevate the head of the bed, try to reduce the use of narcotics, and educate the caregivers as well that this can be an issue. Urinary retention can be a problem. It's one of the problems we still deal with today. From my perspective, it's important that the patients do void prior to leaving the facility. If there's a question about retention, we can check a post-void residual with these fancy ultrasound machines, and if necessary, we can straight cap these patients. But I think it's critical that you educate the patients as well as the caregivers, because if they cannot void, this complication of getting a neurogenic bladder can be really catastrophic. I've had that happen, and it's really a problematic complication. In summary, I think teamwork and planning can absolutely facilitate total joint arthroplasty. patient screening is critical. I think the anesthesia and pain management are one of the really critical components to this. You need their buy-in to have this be a successful program. Obviously, anticipate these problems and have a backup plan. But this has been extremely successful in our facility, and it continues to grow. At this point, I appreciate your attention. I think we'll turn over the mic to Dr. King, and he'll talk about his experience and data as well.